Okay, good morning to everyone. Thanks for the invitation. So I was asked to talk about prevention on atrial fibrillation in cardiac surgery. Nothing to disclosure. The objectives of the talk is to review and update the most promising strategies to prevent AF in cardiac surgery. I will start summarizing all the strategies that we are going to look at this talk so that you can get it easier. So first of all, we should recommend to continue beta blockers, chronic beta blockers until the day of surgery. Beta blockers may be started 2-3 days before surgery if not contraindicated. We may consider to use oral amiodarone a few days before surgery in high-risk patients. Conflicting evidence for sotalol and ranolazine that we will look into it later. Intraoperatively, we may consider to use landiolol, which is a beta blocker with less inotropic negative effect with less risk of bradycardia, more suitable for cardiac surgery. We should consider to use magnesium. We may consider to use biatrial pacing for high-risk patients. We should consider to use vitamin C, lately some papers coming up. We should consider to use NAC, or may consider to use NAC, sorry. We should consider to use posterior pericardiotomy. And in the post-op, we should consider to restart beta blockers as soon as possible if stable cardiac output and depending on the hemodynamic and conduction status. And we already talked about the rest of amiodarone ranolazine. So the incidence of AF, it goes anywhere from 30 to 40%. Greater risk when combination CABG plus valvular surgery. Risk factors associated with AF. We know advanced age, very important one. Left atrial enlargement as well. Diastolic dysfunction, just 3 years, a paper was published relating this diastolic dysfunction with AF, congenital heart failure, and COPD as well. Pathophysiologic mechanisms, the most important one I would say is inflammation due to manipulation and CPV, but also oxidative stress, electroremodeling, atrial incision, and ischemia. We know that atrial fibrillation is associated with an increased risk of stroke, AKI, and death, and consequently increase of ICU and hospital length of stay. So beta blockers, as we were saying, we should consider to continue until the day of surgery. Beta blockers may be started 2-3 days, ideally 1 week before surgery if no contraindication. Most of the patients, they have the indication of beta blockers. Carvedilol more effective than metoprolol because it has a class 3 effect added to the metoprolol one. The landiolol that we were talking about is more suitable for cardiac surgery because it has less potent negative inotropic effect than esmolol, and it has been shown to decrease the risk of AF with no risk of bradycardia. So if I had access to landiolol, I would use landiolol. So randomized control trial from 2015, 60 patients, all with LV ejection fraction less than 35%, 50% of the patients on pre-op chronic beta blockers, and they saw lower BNP and ischemic biomarkers associated with the use of landiolol, less risk of AF, and less hospital stay with no difference in mortality. Last year, a meta-analysis came up with more than 500 patients. Most of the studies, they started landiolol intraoperatively, anywhere from 2 to 10 mics per kilo per minute for 2-3 days, and they saw less risk of AF and less hospital stay with no difference in mortality. So in the post-op, early reinstitution of the beta blocker should be considered. We also have some data suggesting that oral metoprolol once a day immediate post-op in patients with no previous beta